So welcome to Raaonline, and the second part of my talk compared to the previous drug for constipation. This is the anti-diarrheals and drugs for inflammatory bowel disease. So here we are going to see about the pathophysiology of the diarrhea, how exactly what is the mechanism behind the reason for the diarrhea, and what are the treatment modalities available to control the diarrhea. And finally, the inflammatory bowel disease we will be discussing, because in inflammatory bowel disease we have got two types. One is Crohn's disease and ulcerative colitis. So where it can be a little bit of diarrheal things, and so what are the drugs comes under that category, that also we are going to discuss. So first, brief introduction. The diarrhea is nothing but the passage of abnormally liquid or unformed stools at an increased frequency. So that is the term which is given for the diarrhea. And WHO basically they say that it has to be 3 or more loose or watery stools within a period of 24 hours. So more than that they can classify this as a diarrhea, right? So the diarrhea is happening mainly, why it is happening? Because of the decreased electrolyte and water absorption. So mainly the water and electrolyte absorption will be decreased. That means the sodium potassium ATPase pump is blocked, okay? Or it is not that you can say that it is a blocked, but sometimes due to the rapid intestinal transit, say for example if there is a infection, right, bowel infection, where there will be a increase in the frequency urgency, so the peristaltic movement sometimes might be increased. That might also be the reason for the decreased electrolyte and water absorption, okay. Sometimes even the drugs, like for example when you are taking drugs for constipation and other things, right, like stimulant purgatives, which I discussed in the previous talk, okay. So that also what they will decrease the absorption of water and electrolytes, okay. And then increased secretion by intestinal mucosa, right, especially in case of infections and other reasons, the mucosal secretion will be increased, right. And then there is increased luminal osmotic load, that the solute particles, if there is present more, that will also drag more water into the lumen, okay. Then finally the inflammation of the mucosa and exudation into lumen. This more commonly you can see in cases of infections, right, or sometimes if you are giving a purgatives which is too high dose, they can sometimes, because of the irritation effect, they can produce mucosal inflammation. So these are the reasons by which the diarrhea can occur. So coming to the pathophysiology of diarrhea, the first thing is secretory diarrhea, that we can classify as secretory diarrhea or motility disorder due to the motility disorder, and then finally the osmotic diarrhea. So secretory diarrhea basically mainly seen in case of infections like E. coli, Vibrio cholera, right. So once I say secretory means the cyclic AMP pathway is involved. That means these toxins which is released from the bacteria, it is going to increase the adenylyl cyclase enzyme, and thereby it increases the cyclic AMP, which is responsible for increased secretions into the lumen, and thereby when the more fluids are there, it can lead to secretory type of diarrhea. Motility disorder diarrhea is nothing but in irritable bowel syndrome. You have got either it may be a diarrhea or constipation variety. Suppose if a diarrhea variety, because there is some problems with the motility, right. So because of suppose if the motility is inhibited, that means the peristaltic movement is inhibited, then it can lead to a constipation type of irritable bowel syndrome, okay. And then if it is a increased motility, then it can cause diarrhea type of irritable bowel syndrome. So it can be either type. Coming to the osmotic diarrhea is mainly due to, as I told you, the solute particles are there, right. For example, if there is a disaccharide enzyme like lactase enzyme deficiency, what happens, the particular thing cannot be degraded. So based on that solute particles, it will produce osmosis, so more water will come into the lumen. That is the main reason why this osmotic diarrhea can occur, okay. So these are based on the pathology, the diarrhea can be classified into these 3 types. So if you take for example sodium and chloride absorption, mainly it is linked to the glucose uptake by the enterocyte. That means if you see the picture here, this is the cell membrane, right, and you have got the transporter for the sodium glucose co-transporter. So normally they both, one molecule of sodium as well as one molecule of glucose will be simultaneously carried inside to the cell, okay. So what happens, and see, you can see the water molecules here, and this water molecules is they all also follow the same direction of movement, Okay, so that is why if you give a case of diarrhea, like only if you give glucose, right, it is not going to go inside. So what happens, the glucose is got hyperosmolar, so it is going to drag more fluid interstitium to the lumen, and more water will be present in the lumen, causing severe diarrhea. So glucose should not be given as a standalone in the treatment of diarrhea, right? So it has to be combined with sodium. Okay, so that is why if you see the oral rehydration solution, it will have both sodium and glucose together, and of course the water also, they also follow the same movement in the same direction. So naturally slowly the water molecules will get inside, sodium and glucose also comes along into the bloodstream. Now if you see the pathophysiology again, see, as I told you, one is the toxins which is released by the bacteria like cholera toxin, Staph aureus, Salmonella species, Entamoeba histolytica and Clostridium difficile. So from these organisms it will release the toxins where it is going to increase the cyclic KMP or cyclic GMP. The more common is the cyclic KMP, it will be stimulated. And what does it do? It will increase the more secretions, right? More secretions into the lumen. And also it inhibits the sodium chloride absorption in the villus cells, right? So these are the two processes that happens, and finally there is a net loss of salt and water, right? So this is the way how these toxins will act. And similarly in carcinoid tumors, if you see, more serotonin is present in the enterochromaffin cells, and in the carcinoid tumors is present in the enterochromaffin cells, more serotonin is released, and they also goes through the same process by stimulating the cyclic KMP and thereby inhibiting the sodium chloride absorption, and more secretion will be there into the lumen, and thereby the loss of salt and water will happen. Right, so this is the pathophysiology, what happens exactly in the diarrhea. So now for management there should be some principles. What are they? First thing is you have to fluid replacement. There is a fluid depletion is there, so you have to correct with the fluid replacement, right, and so that you can correct the shock and acidosis. Right. Next thing is you have to maintain the nutritional status, and finally comes the drug therapy depending upon the etiology. Okay, so first thing is the fluid management, then the nutrition you have to maintain, then comes the drug therapy. These are the principles of the management of diarrhea.